first of all, welcome and thanks for taking time out of your day today to attend this webinar. It's the second in a series that's focused on the opportunities to impact the outcomes in this post-acute stroke population. Today, we're going to focus on the value of implementing the Kandu Stroke Recovery Program, and we're really going to dive into the details about how Kandu comes to life inside of a hospital-based stroke program. We do have a few housekeeping items to get us started. All participants are going to be muted. We are definitely going to have time to answer some questions at the end of the presentation. So I'd encourage you to submit those. If you'd use the Q&A feature in Zoom and preferably not chat, that'll help us out. We are going to be recording this webinar just as we did the first webinar, and we're going to make it available on our website. That's kanduhealth.com. And at the end, we're going to provide some additional information on how to connect with Kandu. If you missed our first webinar, you can watch it via link on kanduhealth.com. That first conversation really offered perspectives around the challenges that hospitals face with the stroke population, especially with increasing accountability for outcomes and these continued good results that are required after the patient leaves the care of the hospital. We're going to build on those topics today. We're going to be providing insights and strategies around getting started, what to expect when you work with Kandu. We're going to try and do that by continuing to bring you valuable content. We're going to leverage some experts and insights from some of your colleagues to tell that story. My name's Clayton Duncan. I'm the commercial lead for Kandu. I'm coming to you today from a hotel room in Knoxville, Tennessee, but I'm going to be joined virtually by Dr. Tudor Joven, who is the chairman and chief of neurology at the Cooper Neurologic Institute in Camden, New Jersey. Karen Seagraves. Karen started her journey in stroke as a stroke bedside nurse. She's also served as an executive leader for multiple neuroscience programs. Leah Chu, who we're fortunate enough to have leading our client services team, and also Kirsten Carroll, who's our CEO. I'm going to kick off this discussion with an overview of the program. I'm going to be followed by Leah. Leah's going to describe the process and timelines around implementation, and we're also going to share some data and visibility that's created by working with Kandu. We're going to be joined by Alex Schmidt and Amanda Webb from Krista Spawn. They're going to share some of the lessons learned from a recent implementation. Dr. Joven and Karen are going to be providing their perspectives from the chairman's seat and hospital administration about why this is such an important issue for your hospital, why administrators are excited to address the need, as well as how hospital executives really evaluate initiatives like Kandu in an effort to really start this conversation within your program. Before we get started, we had so much feedback on our first webinar. We wanted to introduce an integrative, interactive polling question. We're going to tally these responses. We're going to share them with you as we go. Important note, these answers will all be aggregated. We aren't going to be sharing any individual responses. So as a warm-up to get in a few practice swings, we wanted to use the first couple of questions to get to know our audience a little better. And so we've designed these first couple of questions to really tell us about yourselves. And so I'll run through these first couple of questions. So to tell us a little bit about the size of your program, if you added up all of the ischemic and hemorrhagic strokes that you discharge over the year, tell us a little bit about what that quantum of discharges looks like, both for ischemic and hemorrhagic strokes. I'll give you just a few seconds to answer, probably 5 to 10 seconds. Okay, it looks like we have a pretty broad representation on the call. Most programs are going to fall, between the 300 and 1,000 discharge level. We do have a couple on here that are slightly larger, 600 to 1,000. So, yeah, thank you for that. We just want to make sure that we're tailing our conversation for you. Second question, tell us a little bit about the certification level of your program. So again, I'll give you 5 to 10 seconds just to respond to that, and I'll share some of those results with you. Okay, let's see if I can see those results. Looks like most of our attendees today are either with a primary stroke center or a CSC. We have a few that aren't yet certified or aren't certified. So thank you for those responses. That'll help us tailor our conversations with you as we go forward. Um, Before I hand this over to Leah, I did want to provide just a brief review of Kandu. Most of you know that our mission is to improve the quality of life of stroke survivors. That's what we rally around. We focus on driving outcomes in this post-acute population. And when we focus on creating positive outcomes for the stroke survivors, we also create the chance to impact metrics that matter to the hospital, such as hospital stays, readmissions, really lowering the cost of care to the system, which is ancillary to the benefit of really focusing on what's going on with these stroke survivors as they transition home. When we talk about Kandu, we describe ourselves as a tech-enabled healthcare service. We do provide remote navigator-led support to stroke survivors and their care partners after the hospital discharge. We offer a 90-day program where the survivors and their care partners have access to a multidisciplinary team through a relationship with a dedicated navigator. Our navigators are experienced in and specialty trained in stroke recovery. They are licensed clinical social workers. They are occupational therapists. The connections between navigators and stroke survivors are made remotely. It includes video meetings, telephonic exchanges. These include scheduled weekly check-ins as well as asynchronous communications between the navigator and survivor. The navigators really serve as the quarterback to prepare and assist these stroke survivors with what comes next, what should you expect, and how can we help. To extend the impact of the navigator-led activities, we also developed a communication platform that works for this population. We based our design and the functionality of the platform on the guidance we received from stroke clinicians and, importantly, stroke survivors. They shared with us what they needed. They shared with us how they needed it to be built so that they could engage with it and derive value from it. For those of you that have seen our platform, you know it's not fancy. We say it's not whiz bang. It's really designed for those survivors that have attention deficits, physical deficits, cognitive deficits. We like to say that it's designed for that 70-year-old that's just experienced their first stroke. The application is integrated with our web portal and our database on the back end. It has real humans, those navigators that I described earlier, standing behind it, who are paying attention to everything these stroke survivors are doing, guiding their stroke survivors to relevant content and pointing them to what to do next. We also built in robust monitoring. So we focus on patient-reported outcomes. We have validated assessments for measuring depression, anxiety, caregiver strain, the ability to perform activities of daily living, and certainly function. And we perform these assessments and engagements over the course of this 90-day program. So we measure at the beginning, middle, and end. We covered a lot of this information in our first webinar, but what we didn't get to was, how do you implement this program? What is it going to look like during the implementation process? How do we advocate for this within our system? What's it look like when the program's humming? So with all of that, there's quite a bit going on. Certainly the first question we get is, what's it take to stand this up within my hospital? And so for that, I'm going to hand it over to Leah. Leah, I'll let you take it away.
Great, thanks, Clayton. I'll walk us through the implementation process and the resources required. One thing to keep in mind is when implementing the Kandu program, it's fast, it's easy. This is not like an EMR implementation that's complex and requires a lot of configuration and resources to support the process. The bulk of the implementation activities are owned by the Kandu team. And a lot of the work that we do is really understanding your workflow. We want to ensure that we're fitting in seamlessly into your day-to-day workflow. So let's take a look at 3 components of the implementation. One thing you'll want to think about is who to engage in the process. One of the first things you'll want to do is identify a project lead. This is typically a stroke coordinator, and we'll work with this lead and the executive sponsor to meet with the various teams listed here. During the contracting process, we'll be meeting with administration and leadership. We'll meet with IT to conduct a security risk assessment, and that's probably the only time we need IT support. The other time may be if you would like us to have read-only access to your EMR. That allows our team to easily pull discharge information. But we've intentionally made the implementation very light from an IT perspective. When thinking about the timeline and the implementation plan, on average, it takes 2 to 3 days to implement the program. We'll typically come on site for a few days. We meet with the various teams, and we can actually train and go live all during that one visit. Scheduling is really flexible, and we'll work with you to accommodate your needs. If you would like to have some remote meetings and then a shorter on-site visit, we'll work with you to accommodate what works best for you and your teams. And then as we're meeting with you, we'll be learning a lot about your goals, your priorities, what data is important to you. We want to ensure that we're capturing that data, that we're reporting data, and that we're delivering that data back to you. We do have standard dashboards that will be delivered to you, and we'll be reviewing some of those later in the webinar. There's 3 easy steps to implement the Kandu program. The total duration of these steps combined is about 13 hours. And once an agreement is signed, the first thing we'll do is schedule an introduction call. This is really where we talk about the implementation timeline. We'll start planning for that on-site visit. Some of the pieces you'll want to start thinking about in preparation for the on-site visit is identifying your lead, thinking of who needs to be involved with the extended team meetings, if there are any post-acute care partners that you'd like us to meet with while we're in the area. And then you'll also want to start getting a list of in-system resources. So this would be both in-system resources and community health organizations that you recommend. We'll map these local resources to needs so that our navigators have everything they need to solve for both SDOH and healthcare needs. The second step in the process is the discovery session. During this on-site meeting, we'll meet with the stroke team. We'll ensure that we understand the current workflow, who does what when. We want to ensure that we're incorporating the Kandu referral process into your existing workflow and not disrupting anything that you're doing today. The meetings with the extended teams, such as case management and social work, those meetings are much shorter. We only need about 30 minutes to an hour with those teams to educate them on the program. And then the third step is to train and go live. Following training, we will work to shadow the discussion. So we'll follow the care team, visit in the patient rooms to introduce the program, ensure that the care team is comfortable with completing the registration process. Our goal is to really ensure that you're comfortable on how to speak about the program and how to refer patients successfully to the program. So let's review some training and supporting resources. This is Alex Schmidt and Christina Peretz from Christus Swan Shoreline in Texas. We recently implemented there. You can see in the picture some of the supporting materials we provide to you for the registration process. We'll also provide you with posters that you can hang in patient rooms, hallways, waiting areas. These posters will help inform survivors, families, and care team members of the program. When we train the stroke team, that typically takes about 2 hours. And during that training, we'll review in detail the materials. We'll provide you an introduction guide. It contains a script so that the care team knows how to describe the program. We'll provide flyers that are distributed to the survivors and families. We also will share online resources with you that contain videos from prior Kandu graduates, along with FAQs and other supporting materials. So as you can see in here, this is not your typical software implementation. It's simple, it's quick, and you can rest assured that we will support you throughout the entire process. Let's take a minute for a quick poll. What would be most impactful to your hospital when adopting a principal illness navigation program such as Kandu Health? If you could please select the top two. All right, looking at the responses. It's not surprising to see that a lot of these are very diverse. It just goes to show that a lot of priorities and goals differ site to site. Part of our implementation process is to really work with you to understand your priorities, your goals, what's important to your program, so that we can ensure that we're prioritizing and measuring those things as we're working with you. Next, we'll watch a short video from the team at Christus Spawn Shoreline, Amanda Webb and Alex Schmidt. They'll share why they chose to implement the Kandu program and what their experience has been like in working with us to date. They really wanted to be here with us today, but unfortunately had a prior commitment. And I do want to take a minute to just say how wonderful it is to work with this team. They've truly shown how easy it is to contract for and implement Kandu. And we're just very appreciative of our partnership and excited about the work that we're doing together.
Sure. I originally started out as a stroke coordinator here about 8 years ago. And I'm currently the administrative director of nursing for our neurotrauma service lines, as well as the regional director for the neuroscience service line.
My name's Alex. I originally started my nursing career in New Zealand, where I trained and got my BSN. And then I moved to America in 2018 and moved to Corpus in 2019 and began my American nursing journey, which brought me to Shoreline. And I was able to become part of the stroke program, and I really enjoy what we do here and think it makes a difference.
We help to get these patients to their best place possible to be able to discharge. And we do those 7-day follow-up phone calls with patients, but from that point on, we really lose contact with the patient. So including Kandu into our program has really allowed us to have that full continuity of care and follow these patients for a longer period of time to ensure they're being seen by their primary care providers, to ensure they're on the right medications to prevent those future strokes and future hospitalizations. Kandu has done majority of the work. So we, have to get the ball rolling with the contracts and such, but as far as education, they've done a great job of providing those resources to be able to speak to our teams, speak to our nurses, really let everyone know what Kandu is all about. Kandu has done a fabulous job of really speaking with all stakeholders, from bedside nurses to the VP of operations, to ensure that everyone understands what they're about.
So when we first rolled out the program, we would meet weekly with the Kandu team and discuss any outstanding issues or patient cases that were concerning. The other thing that we discovered after we implemented Kandu that we hadn't kind of thought about was the direct communication that patients are now going to have with the in-hospital side. Since we do have those those meetings. The navigators from Kandu participate in those. They give us updates on patient care, how they're doing. And then if there's any like concerns that the patient may have, we can discuss those in real time and they can report back to the patient without, a delay.
I would say one process flow that we are looking forward to, we haven't quite reached that time frame yet, is that 90-day modified Rankin being able to help us collect those. We're getting close to that point, so we're excited to see where these patients fall. But that will be a big help in our process, and help release some resources that are currently doing those calls to capture those 90-day modified Rankin skills.
They also have a really good percentage rate for collecting those, which was above and beyond the national standard, which was amazing. So I'm really looking forward to seeing those results when they're available.
I'll introduce Dr. Tudor Joven. Many of you probably already know Dr. Joven. He's an internationally renowned stroke expert and researcher who has made incredible contributions to innovations in the stroke industry. As chairman and chief of neurology at Cooper University Hospital, he understands that the survivor's journey through stroke recovery extends far beyond that initial event, encompassing the critical issue of readmissions. So with keen insights, he'll shed light on why stroke readmissions matter, offering a chairman's perspective. Dr. Tudor Joven.
Yeah, hello, can you hear me?
Yes, Tudor, we hear you. Thank you.
Okay, great. So thank you first to everybody for being here. It's great to see the interest that this company has generated. I can provide my perspective as, first of all, as a stroke neurologist and interventionalist, and second as a department chair and neuroscience service line director. So, why, and also we've been lucky to have Kandu here at Cooper. So just like the previous teams, I can speak from my own experience, and that from my staff and our patients, what impact Kandu has made on patient care here at Cooper. So first of all, we're talking about the benefit of a service like Kandu. First and foremost, we care about patient outcomes. That's the mission of this company, just to improve the quality of life, improve the integration back into society of patients who have had a stroke, which even to my surprise, after so many years of working exclusively with stroke patients, I realized that we're not focusing enough on this aspect of the experience through which stroke victims go through. We tend to be more focused, and based on the nature of what I do, stroke interventions, that's sort of the glamorous part, and we are focused on opening up the vessel that's occluded, and that makes a huge impact on people's lives, don't get me wrong, but you get to realize that that's not everything, and unless you address every aspect of these people's lives, you're not finishing the job. You're not really doing them the service that you should be doing them. So the first and foremost goal is to improve outcomes. And I think based on my experience, certainly patients seem to be better. And you've heard this not only from me. So I think that's something that the signals that we're getting from the experience that we have so far with this service are pointing all in the right direction. But in order to build something that's sustainable and offer something that's sustainable, you have to also make an economic argument for it. It has to not only be, unfortunately, in the climate we live in and practice in, things don't only have to improve patients' experience and quality of life and outcomes, they also have to be economically viable. So that's one part that we're focusing on here. And a big story of the economic viability of this platform is preventing readmissions. So we don't only have to show that patients' outcomes are better, their experience is better, but also that this is being done in an economically sustainable way. A big part of that, it's not the only part, but it's a big part of that is readmissions. And why do readmissions matter? Well, first of all, it's been shown time and again that readmissions are a prognostically unfavorable factor for patients. So if we decrease readmissions, we make patients better. Second, from an economical perspective, readmissions are a big money loser for hospitals from many standpoints. If we look at the simplest way to explain why a readmission is detrimental financially for a hospital, you look at the bundled care model, and that's very simple. You get a fixed amount of money to provide care. Any kind of hospital admission is expensive. You incur a second hospital admission, you take a big hit, and that gets subtracted from the fixed amount of money that you get to care for a patient. But even in the conventional, the classic model, readmission cost money because nowadays, as everybody knows, there's penalties incurred by Medicare. And many times, it depending also on the insurers, the second readmission or the readmission, the second admission, does not get reimbursed anymore. And even on top of that, beyond that, maybe that financial loss is not that high, although every admission costs money. But on top of that, you're missing the opportunity to admit another patient. A lot of the hospitals that we operate in at large stroke centers, and any stroke center, I would say, are busy hospitals. Many hospitals are at capacity. My hospital is always at capacity. Any readmission means the opportunity to admit another patient who would actually bring money to the hospital. So for many reasons, penalties, lack of reimbursement, bundled care, and the lost opportunity to care for somebody else who brings additional revenue has a negative impact on cost. More and more payers, including Medicare, pay attention to quality of care, and readmissions are a big indicator of quality of care. So not only it's not good for the patients, but we don't look good if we have high readmission rates, and that reflects in all sorts of quality metrics that are now being made public. Has to do with how these metrics lead to marketing strategies for attracting patients and so on and so forth. So clearly, quality of care, obviously something that we're paying more and more attention, tied to all sorts of reimbursement metrics, including at physician level. Many departments now have quality bonuses tied to physicians' salaries, tied to other providers' salaries and bonuses. So this is all part of these quality metrics. Resource utilization, as I mentioned, you're utilizing resources with readmissions that otherwise would be allocated to patients who would bring revenue to the system, and it's a missed opportunity to get additional revenue. And then continuity of care, of course, successful transitions of care are important in avoiding uninterrupted any kind of readmission is a setback in the favorable course of the recovery of a patient. So for all these reasons, readmissions we identified as the key component in terms of making the argument that this is not only a good thing for the patient, but also a good thing for the bottom line. And I will hand it over to Karen Seagraves, who will talk about administrative advocacy, something that she knows a lot about.
Hello, everyone. Before I get started, I've got another polling question for you. We could bring the next slide up. And this is so we can understand a little bit more about who's on the call. And so if you could take a quick look, if you are a clinician, the first 3 apply to you. If you're an administrator, the next 3 apply to you. And if you are both, pick which hat you're wearing today when you're on this webinar. We'll give just a minute or 2 to answer. And this is really to understand your comfort level when you are working across the clinical administrative relationship. Right, we should have our results rolling in. Oh, so we have a combination of administrators and clinicians here, but it looks like nobody is very comfortable. So that is really valuable information, and I am hopefully going to change that right now. So having a conversation about a program can be challenging. Certainly, we want to be sure that you are able to build a business case for a solution that you're proposing, but also that it tells a story. And when I think about how I propose something, if that's the nature of the conversation, I want somebody to understand what is the consequence if we don't implement this program. So some of the things that I might ask if you bring a program to me as an administrator would be, what are the resources that we're going to need if we bring this program on? Financial resources, certainly, but also what kind of human capital? So who will be involved in an implementation, as well as any kind of capital equipment. So do I need to purchase any items for the implementation? The next thing that I'm really concerned about is the reach of the program. How many people in my hospital, whether, if I'm talking about my patients, can I serve with this program? Is everyone eligible for the program? How will they access that program? And then scalability. Can this be expanded across different disease states or units or sites or hospitals or clinics? The reason being that there are so many solutions out there now that I want to know that if this is going to be a one size fits all, or at least most, to see the value. Innovation and adaptability of a program really speaks to how healthcare is moving at the speed of light these days. So if you implement something and then perhaps change your EHR or integrate different systems into your hospital, will the program still work? Is it adaptable? Is it flexible? And how will we be able to essentially move forward with the program in a new environment? Effectiveness and sustainability, I would like to know, how will the program be measured? What will be the indication that the program is working? What kind of data and metrics are we going to be required to collect and the resources needed to do so? And then how will others be involved? So is this going to be something that empowers staff, my clinicians, nurses, providers, patients and their families? And lastly, but certainly not least important, is it an evidence-based approach? What are the data behind the program? Will it be updated as clinical practice guidelines change or as information changes in the field? And who is responsible for doing so? Now let's talk more specifically. Dr. Jobin did a phenomenal job outlining so many of the problems that we have in healthcare and particularly in stroke care. So before proposing a solution, it's important to understand your program's data. So I would recommend familiarizing yourself with your readmission metrics. Who's coming back? When are they coming back? Are we looking at the 30 or the 90 or even the 1 year readmission rates? Tracking the capture of modified Rankin scale scores, not just so that we understand the clinical outcomes of the patients, but because it is very important in recognizing if there are things we need to change in our acute setting and as we manage the program. Explore the connection between your discharge procedures that you currently have, the programs you have in place, and the protocols you have to reduce readmission rates. Perhaps they're not working, or you've tried a lot of things and you just haven't hit on the right solution. Or maybe you haven't had a solution yet and you're getting ready to think about what should you implement. Also gaining insight to your hospital satisfaction scores. Very often, if you're a center that can drill down to the stroke level, you get very valuable insights about how your patients and your families perceive your program. And of course, understanding how programs can bring financial benefit to the hospital. I know we spoke about penalties so that if patients are readmitted or utilize the emergency department for care, you can be penalized. But there are lots of ways to generate revenue when you keep patients happy and within your system, including their follow-up care and leveraging other resources you offer, perhaps imaging down the road, wearables for managing their care. And then we're going to speak a little bit more specifically about what does success look like with Kandu Health. Avoidable emergency department utilization because you've got somebody who's holding the hand of your patients and their families after they leave your acute setting. So you've got continuity of care, you've got improved satisfaction, but you also have increased compliance with the plan of care. So success means we know what we're supposed to take, we are able to get our prescriptions, and we're compliant with those medications. Additionally, compliant with the post-discharge instructions, understanding what the instructions are, and really being able to be compliant with that plan of care. That includes follow-ups, that includes rehabilitation therapies, and that improves the overall quality of care that your system is providing. You are able to retain patients in the hospital system when they are getting the care that they need and the care that we know as clinicians we really want to be able to provide. And that results in a reduction in burnout. When you think about your staff and the teams taking care of the stroke patients, there is so much work on the front end. We focus so much on the door twos, but when we don't have the time to provide that holistic care that we are trained to give and to give that education and those resources to families because we are trying to make room for the next patient, it is disheartening and it can really damage that satisfaction of the folks who work with you and for you. So next, Kirsten, our CEO, is going to discuss with you our Kandu Stroke Recovery Program assessments and the reporting that we're able to provide back to your hospital.
Thank you so much, Karen. Really appreciate it. So we're going to start. We know how important data is to these programs. We know how responsive they are to data. So a couple polling questions to get a sense. The first one, if you look across the whole service line, so not just the lytic and thrombectomy patients, but every stroke patient that you're serving, for what proportion of that population are you successfully collecting your 90-day modified Rankin scores? So we've put this in quintiles, 0 to 20, 21 to 40, all the way up to 100. Or do you not know how successful you are in collecting your Rankin scores? So we'll give it a second to go ahead. I know it takes a moment for the data to process. And we'll get a sense of the success rates in capturing these Rankin scores across the service line. Okay, and so yeah, this is what we tend to hear. So we have about 40% reporting that it's less than 20% of the full service line. About 40% is 41 to 60%. And then another 20% is actually getting over 60% capture rates. And so we hear this a lot. The majority of patients in the service line, we don't actually know how they're doing 90 days after the stroke. And some of that is driven by who you are required to actually collect that data on. The next question, we've talked so much about the importance of readmissions. And so this question is, are you confident that you know your all-cause, all-facility readmission rate at 30 days? So not just the recurrent strokes coming back to your service line. Do you know what % of your patients are having some level of readmission for any cause at any hospital within 30 days of the stroke? Are you confident? And that's just a simple yes, no. So we'll give it just a moment as people think about that. Are they confident? It'll be just a moment to process that data, and then we'll see how the room is feeling. So about 80% are not confident that they know their 30-day readmission rate. And that's not surprising because this is actually really hard to track. I think one of the exciting things with interoperability and health information exchanges is we're getting new tools to learn to track this across centers. But we do hear so often from people in charge of stroke programs, they don't know how they actually did on this metric until the penalties come in. And by then it's too late to change things. So we're going to talk a little bit now about the ways that Kandu can actually help you continuously track your performance in real time. That allows you then to identify trends, actually measure the effectiveness of the programs that you've put in place to try to improve your outcomes. It allows you to make data-driven decisions. So it's not just sort of hypothesis and conjecture and loudest voice. Learn where you can continue to improve. And most importantly, we say this again and again, this is all about optimizing the patient outcomes. The more you know, the better you can serve these populations. So we really built Kandu for data collection. We wanted to make sure that as we are reporting data back to our centers, that has very high integrity and accuracy. So our teams are constantly getting their data from multiple places. We have very high engagement with patients. The patients on average spend 6 hours over about 10 touch points with the navigator while they're in program. So we get patient-reported data on have you been readmitted and how are you doing. We do monitor the health information exchanges and the admission discharge transfer feeds, and we really find that you need to do both of those things and hear from the hospital. And it's with the hospitals telling us, the HIEs and the patient self-reporting that we really get those holistic pictures of the readmissions and the outcomes. And then we talk about that with the hospitals, often in real time. A patient's been put on OBS or is in the ER, this is what's going on, and that allows people to help those patients in real time. So we're going to look in the subsequent slides at some of the things we report, and it's a really broad set. I think in big buckets, we're looking at who are we serving, both in terms of demographics and quantities. We're looking at our operational metrics for how we're serving them. And then we're looking at the outcomes. Are these patients ultimately doing well? So I'm going to invite Karen back. And as I go through these on some of the slides, I think Karen's going to have some comments about how as a bedside nurse and as a administrator, some of these things would have mattered to her to have in her program. I think the first one is pretty straightforward. This gets to that question of reach, but how many people are being referred, how many are consenting to service, and how many are enrolling and graduating in the programs. And so we do hold ourselves accountable for this. There's no joy in implementing a program that's then not getting utilized. So we look at this every month and talk with the site. How can we do better? Are we serving the population they're interested in? Why are people declining? And is that something we can address with further programming? The next slide then actually looks at the demographics of that population in more detail. How old are they? What is their race and ethnicity? And also, as they enrolled in the program, which is typically a week or two post-discharge, what did the Kandu clinicians see when they did that initial enrollment modified Rankin score?
And Kirsten, there's so much value here because we want to make sure that when we offer a program that everyone has that access and eligibility, and that we are making sure that we're not approaching only subsets of our patient population. And I think we're going to move into some discussion about the diversity of patients, I think in another metric. And I'd like to add some color there.
Yeah. And there's so many sort of components of diversity. I think one thing you'll note in our chart here is that we're reporting race and ethnicity all in one group. There's actually a new rule that came out from OMB just a couple weeks ago. They are changing the way that they are asking federal agencies to collect race and ethnicity data. They expect all federal entities to be compliant in time for the next census, but they are no longer separating race and ethnicity. So you talked earlier about flexibility as guidelines and new reporting requirements come out. Who can quickly adapt to that and update the measures, the reporting, the categories to be compliant with the measures the government and other regulators want. So this one actually looks at the social needs of patients. And so we talked in the last webinar about how we do our SDOH assessments. On the left side, you can see what proportion of patients have each social need. That does not add up to 100% because many patients have multiple. And on the right, as we talked about, the team is deploying resources not just for social needs, but also for healthcare needs. There's a reason it's a multidisciplinary team. So we're reporting back to the hospital how many resources on average are your patients needing for connections, and what are those needs that are really rising to the top.
And I think what speaks to me the most about this one, Kirsten, is that these aren't just things you've identified, they're things you have addressed. And if you look at the social determinants of health, this really speaks to some of our newer focus on and also regulatory requirements around looking at those disparities in care and how are we meeting the needs of that broad patient population, not just the ones where it's convenient or who are in your nearby catchment area or who have resources.
Right. And then the next slide is on the readmissions. And so again, I talked about we're hearing from the hospital when they know a patient has been readmitted. We're monitoring the admission discharge transfer feeds in real time, and we're hearing from patients. And so what we report back to the hospital every month is not just the 30-day and 90-day readmission rates, but actually the causes and the timing of those readmissions. Is the problem recurrent stroke? Is it UTIs? Is it lupus flare-ups? And really letting the hospital know in real time how these patients are doing and where they're utilizing care.
And as an administrator, I can tell you this is more information that I routinely receive about my population.
Yeah. Yeah, it's so exciting sharing with this, and very often it turns into learnings about what more can we do. And so just in the last year, we've developed so many new programs to avoid these unnecessary readmissions and also to prevent the things that are causing them. Each patient, we provide a narrative as they graduate from the program. What outcomes did they receive? What services did they receive? Any qualitative notes? And very often patients actually stay with us after graduation. They continue to come back to Connect groups. We do 6-month and 12-month self-reported measures for these patients. And it is so rewarding. You talked earlier about burnout. It's so rewarding for the teams to know this level of detail on the patient's lives, quality lives, and outcomes. So this is one of the things that's the most fun to report back to the hospital with regularity. This is the 90-day and the 30-day modified Rankin scores. You don't often see movement at 30 days, but we still collect it and report it. You see more movement and improvement by 90 days, but we'll tell the hospital each month for each person enrolled in the program, how many days post-discharge are they now, and if we've collected the score, what the score was at each of those time points. And that really gets then to supporting hospitals in their Joint Commission and DNB certifications. There are a lot of things Kandu can speak to and how we're helping programs meet some of those guidelines for the primary comprehensive thrombectomy capable centers, whether it's in education, follow-up adherence, reporting metrics, health equity. With every site that we work with, we support them, whether it's in most cases now it's been both providing the data in advance and actually joining them in person in those certification visits. So now I'm going to hand it off to Clayton to close and take a couple questions before the top of the hour.
Great. Thanks, Karen. Thanks, Kirsten. Have really enjoyed this conversation today and thinking about how this would impact so many of you that are out there in the audience. You know, the theme of today has really been how to seize this opportunity to address this post-acute stroke population. um, our goal is really not only to make that implementation easy, but also the investigation. We like to use, you heard me say this before, we like to use relevant system-specific data. We like to partner with the clinicians to build not only the clinical case, but also this business case. One of the things we haven't really talked about is when do we get engaged? When do we go over to the administrative side and work with that dyad? We found that it works to partner with that administrative side early and often. I would say, uniformly, the clinicians see the value immediately. You know what this means on your program. You know what it means to your patients as they go home and think about outcomes. It takes a little bit of work just to make sure that that story is cohesive and fits in with the administrative goals, but ultimately they're in this to provide great patient care and outcomes as well. So thank you for spending the time. We do have just a couple of questions. We're about to run out of time. One of the first questions was, what types of patients can I refer? Stroke patients, I believe. But can I refer anyone? I'll answer this, and Kirsten, if you want to jump in, we like to make sure that we're providing access to care for all stroke survivors. It's really appropriate for those 60% of stroke survivors that are transitioning home within 30 days, even if they have a stop at rehab. We like to think about this as modified Rankin's 0 to 4 at discharge. We've worked with SNF patients. It's a little bit of a different model. And then as it relates to payer status, we don't want the hospital triaging based upon commercial patients or fee-for-service patients or Medicaid or uninsured. We want to make sure that we're there to help all of those stroke survivors as they transition home.
Yep, I think that's accurate, Clayton. Our goal is to serve every patient, and we're going to continue to expand our programming, our language capabilities to be able to serve every patient. We do not exclude based on payer status or ability to pay. So we don't ask the hospital to overthink that or exclude anybody. And we are committed to continually expanding the program and the reach because we believe every stroke survivor deserves the Kandu program. The program right now, as you said, is for the approximately 60% who are discharging to home or acute rehab.
Great. And maybe we have time for one more question. This one comes to us and says, how much time will be required from my staff when introducing Kandu and onboarding patients? And I believe that that's on a per patient basis. Leah, you've been working with a couple of our recent partners on this, so perhaps I'll let you address this.
Sure. So typically the introduction of the Kandu program and registration is incorporated into that discharge planning and education process. So it can be anywhere from 2 to 10 minutes, just depending on the amount of questions that survivor and family have. A lot of times we just recommend that anyone who's eligible, it becomes part of their education package. They know that we will be calling them, and then the Kandu team can really be the one to take on that work of explaining the program, answering questions, ensuring that survivor understands the program fully.
Yeah, great. Thanks, Leah. I think that's all that we have time for today. Thank you so much again for spending time with us. If you'd like to ask additional questions or understand a little bit more, Shane and I are available to work with your team. We like to work remotely, virtually. We love when we get to come on site and really understand what's driving a program. So this is our contact information. I'd encourage you to reach out to us. Obviously, there's all kinds of information available at kanduhealth.com. And stay tuned for our next webinar series. We haven't quite developed it yet, but we want to build on all the excitement that we've seen from these first two.